Welcome back, everybody. I hope you're feeling nice and refreshed. It gives me great pleasure to introduce our second keynote speaker of the day, which is Professor Salome Maswime. Salome is an associate professor and head of global surgery at the University of Cape Town. She's an obstetrician and gynecologist, a Next Einstein Fellow, and the president of the South African Clinical Scientists Society. She completed Discovery Foundation Fellowship at the Massachusetts General Hospital and Harvard Medical School. She specialized and completed her PhD at the University of Witwatersrand, and she previously worked at Chris Hani Baragwanath Hospital in Soweto as a specialist. Her research interests are in global surgery related to cesarean section and placental causes of stillbirth. She is an advocate for women's health rights and equity in maternal health care. Salome has received awards for her tenacity and commitment to research in maternal health. She was acknowledged as a trailblazer and young achiever by the President of South Africa in 2016, and she's also received the Young Achiever Award from the African Business Network, Africa Forbes, and CNBC Africa Group. She's truly inspirational, and I can't wait to hear her presentation. So over to you, Salome.
Thank you so much, Tina, and thank you to all the organizers for inviting me and for giving me this opportunity to speak. You can put through my slides. So I'm speaking about creating high quality, respectful hospital care, and I'm going to take you through speaking as both somebody who's involved in global health and as an obstetrician and gynecologist. Next. So in much of the world, as we all know, childbirth is still considered to be very dangerous for pregnant women. And, you know, part of the whole maternal or looking at respectful maternity care is looking at how do we improve the childbirth experience, not just the childbirth experience as well as the quality of care that mothers receive. And so over the next few minutes, half an hour, I'll be talking about various ways in which we can do this and ways in which we can think about this. Next slide. Respectful. So the key topics that I cover is respectful maternity care, comprehensive obstetric care. So I'm going to speak a bit from a clinical perspective, looking at outcomes. I'm going to talk about maternal mental health, which is often left out in such conversations. And I'm going to propose a few solutions and approach, also critique some of the approaches that have been there. Next. So high quality, respectful hospital care is divided into 3 components. So it's looking at respectful maternity care, it's looking at high quality comprehensive pregnancy care, and looking at maternal mental health support. And if you combine these 3, you've got women who improve, you have women who enjoy the pregnancy and childbirth experience. You also reduce maternal morbidity and mortality. And so the interlink between these 3 areas is where the real solution is. You can't focus on one without the other. You need to look at these 3 together. Next slide. Respectful maternity care, as we all know, is care that is organized and provided to all women in a manner that maintains their dignity, their privacy, confidentiality, informed choice, continuous support, ensuring that there's no harm and mistreatment. So I'm not going to talk too much about the details about respectful maternity care because we spent the past 2 days really listening to the various components, the various aspects of RMC. And so what I really want into is really what options do we have? You know, I can describe the forms of disrespectful care, verbal abuse, as you know, physical, sexual abuse, refusing to give women access to care, discrimination, failure to meet professional standards of care, failure to provide pain relief, neglect and abandonment, poor rapport between women and caregivers. And I've deliberately called this disrespectful care, but I'm going to go back to this at the end. Next slide. So in opinion, there is no debate. The whole debate about whether we need to invest in RMC, whether we need to create interventions, whether we need to improve the level of care, I don't think there's any debate. We all know that respectful maternal care is a human right. We all believe in this. And so today is not about trying to convince anyone that RMC is important or it's required, but it's really to go into various aspects of RMC and solution and proposing solutions. Next slide. So famous words are not dying because of diseases we cannot treat. They are dying because societies have yet to make the decision that their lives are worth saving. And so we really need to ask ourselves which women are dying, which beings are getting disrespectful maternal care. This happens in high income and in low income countries. I don't think it's just a problem in low and middle income countries, but women that are not regarded highly in society, women on the poorer end of things, are usually treated and abused. Next slide. So, as I said, which women in society experience disrespectful care use? What determines the relationship between a woman and her giver? We need to think about that, because it's not only about prescribing what needs to be done, but we need to think about which women are actually being abused. Is there an association between abusive care and hospitals with tense and toxic environments? So a lot of this has been said, but the attention that is received where healthcare workers feel abused themselves, those healthcare workers are more likely to be abusive towards their patients. Do the social determinants of healthcare also determine respectful maternity care? If you go into work on global health, public health, global surgery, we talk a lot about the social determinants of healthcare, poverty, etc. And hear that even with respect and disrespectful care, there is an association. Next slide. So 810 women die from pregnancy-related conditions daily globally. Majority of it's avoidable. 94% of the deaths occur in LMICs, and most of these deaths occur in sub-Saharan Africa and Southern Asia. And just I'm highlighting these things because, as I said, I want to talk not just about RMC, but the three components of quality maternal care. Next slide. And as we know, it's not just the maternal deaths. Maternal deaths are the tip of the iceberg. For each maternal death, there's a huge number of stillbirths and neonatal deaths. So there's a lot of work that needs to be done. Next slide. This is a study that we did, the African Surgical Outcome Study, where we found that African mothers were more likely to die after cesarean section than moms in high-income countries. This was a study that was published by The Lancet in 2019. Next slide. The work has been mainly around cesarean sections and stillbirths. And so questions are, why do pregnant women die? Why are they dying? Because of lack of access to healthcare, because of delayed access to healthcare, of specialists in places where you need multidisciplinary care, and the patients are being treated by medical officers. And it's not to say that there isn't a place for task shifting and task sharing, but often patients start having complications like obstetric and have multidisciplinary care available. Patients will die because they won't receive the best care that they can receive. Shortage of equipment, resources, poor infrastructure, poor preoperative care and postoperative care and poor rating. So I'm just putting in all of these because these are ultimately linked to the full comprehensive quality health care that a woman needed to achieve. And if you don't have these things in place, women will have adverse outcomes. Next slide. Pregnancy is over many, it much as it's a joyous experience, but there's a lot of anxiety, there's a lot of fears women have as soon as they find out they are pregnant. So maternal mental health an important component of the care. Not every is planted that we know, and some women will suffer from depression. And women who are depressed also neglect their children as well. So it's important to look at all of this together. Women who feel disrespected will not attend antenatal clinic, will not have a safe childbirth, and women who are depressed and have bad experiences will also have poor bonding with their children, and their babies will also have poor outcomes. So it's important to look at the comprehensive picture. Next slide. About 10 to 13% of women who have experienced childbirth have had a mental health disorder. More women living in developing countries experience depression, and mental disorders are treatable even by non-specialist providers. So also to just remember that we have to include all of this into the full care package. Next slide. Maternal mental health, maternal health, what are the determinants of care, which I've mentioned: poverty, unequal access to education, women coming from places where they've got food and water insecurity, and discrimination as a whole. And what are the causes of death? The leading causes of death, of course, obstetric hemorrhage, infections, medical disorders. And so often as clinicians, we look at the column on the right and we try to address each of things, increase the blood, increase antibiotics available. But the real women who suffer, who are disrespected, who die, and who are poor, who are not educated, who come from areas who are discriminated against. So it's important that we understand the causes and we understand the determinants. If we don't, we'll prescribe solutions that don't address the actual problems. Next slide. The pregnancy and childbirth experience and maternal mental health are neglected because they are not a direct cause of maternal death. And so if you look back at the work that has happened over the past, decades, the sustainable development goals, the development goals, a lot of emphasis was put on interventions to reduce maternal mortality, because you can count the number of deaths, but you cannot count the number of women that have been disrespected. We haven't quantified that sufficiently. We have not been counting the women who have had mental health conditions and that were directly linked with their pregnancy experience and the outcomes thereafter. So it's important that we start counting these things and looking at solutions are comprehensive. Next slide. So what are the drivers of poor maternal outcomes? It's inequity, understanding the role of women in society. Some societies just do not value and respect their women enough. And that's where abuse happens. That's where these situations happen. Caregivers who experience disrespect and abuse in the workplace will also become abusive. And so valuing our healthcare workers and creating an environment that is conducive to care for others. So caring for the carers, and then social norms, and where things like abuse and disrespect have become normal, have been normalized. And so women don't even put you to complain because they're told this happens everywhere. And so it's starting to look at the drivers and starting to address the drivers and not only addressing the symptoms. Next slide. I'd like to
So I'm
introduce
going
you
to,
to a doctor from Nigeria who's currently doing a PhD looking at respectful maternal care. I'd like you to introduce yourself and tell us exactly what you do and what your background is.
Okay, thank you very much. My name is Dr. Oluwaseun. I am a Nigerian from the southwestern part of Nigeria. I am a medical doctor, and I am currently lecturing at the Obafemi Awolowo University, Ile-Ife, as a senior lecturer and also a honorary consultant with a teaching hospital affiliated to that institution, Obafemi Awolowo University Teaching Hospital. I teach medical students, masters in public health students, and I also coordinate the residency training program at our institution. My areas of specialty is in health management and health systems research, and yeah, that's it.
So tell us why you chose to do research on respectful maternal care.
Okay, thank you. I chose this interest in respectful maternity care was because my core interest is improving quality of health service delivery. Okay, and I know that despite the various interventions by governments to improve utilization of health services for labor for delivery, utilization of health facilities for delivery, despite many of these interventions, we still continue to have increasing mortality across the globe. And one of the reasons I've been stressed in the literature is about the health worker attitude. So I have this passion to see whatever interventions I can bring in to improve health worker attitude. I also belong to a maternal disease surveillance response system in the institution where we review maternal deaths weekly to every 2 weekly, and we try to review the various health system factors that contribute to it. And some of these factors are actually health worker related. And so because of this was my passion to want to reduce this burden and improve health facility utilization for delivery.
So tell me, what's the typical experience for a woman in Nigeria who's going into a maternity care or who's going into a labor ward?
The experience for a normal Nigerian going into the labor ward could differ depending on the type of health facility being utilized. For those going to a private health facility, it might be better. For those coming into public health facility, they commonly experience disrespectful and abusive care, shouting. The women, the health care workers sometimes are very nice, but in most cases can be quite intolerant. So women sometimes get to present very late because of trying to avoid such disrespectful and abusive care. And some eventually don't even get to the hospital at all because of this.
So do you think it's a serious problem? And do you have any suggestions of what could be done to improve the experience of the pregnant woman?
Yes, at the moment, the opinion that the people have towards health workers is not encouraging. And this needs to change. The health workers need to begin to review their attitude and begin to see women as important, as relevant, and as a partner in their management. Women want to feel respected, they want to feel honored, they want to feel important, they want to be happy. There are competitors, the various other alternatives for women that they can readily go into. And so we need to begin to see healthcare delivery from a business perspective. I think that is one major thing, that health workers in government hospitals need to begin to see that they are in a competition with quacks and with traditional birth attendants and other people. And they need to begin to see how many people more they want to have on their side. And they need to be ready to change, to begin to practicing respectful maternity care, women-centered maternity care, so that we can reduce the burden. The burden of maternal mortality in Nigeria is continuously increasing. Nigeria is now the leading country with highest level of maternal mortality, and we need to do something about it. And we need to start with ourselves, not just pointing fingers at government.
Thank you so much. I think that was so insightful. And I mean, you raised so many important points that there's a lot that can be done. There's a lot that we need to do. And the attitudes of the healthcare workers are very important. And especially coming from one of the countries with amongst the highest numbers of maternal deaths in the world, but really that the interventions really need to come from the healthcare workers changing their attitudes, and that will also encourage more women to deliver safely in hospitals. Thank you so much for your time.
Thank you so much.
So I'd like to just acknowledge Sean, who is a PhD student who's doing her a PhD on RMC. And that was just a short conversation with her, and also highlighting some of the issues that I've mentioned. But I've spoken a lot about problems and what are the actual solutions. Next slide. Next. So there are 4 solutions that I want to propose, or 4 approaches that we can look at. One is the implementation approach, and us are familiar with that, a human rights approach, a human behavior approach, and then looking at this from a social justice and equity perspective. Next slide. If you look at the implementation approach, it's really trying to incorporate RMC into different aspects of healthcare and teaching. And so we'd go the education approach and look at what can we add in the curriculum, including teaching about respectful maternity care, teaching about privacy, confidentiality, and making sure that the students, whether midwifery students, obstetricians, registrars, etc., this is brought into their curriculum, and so it will train a next generation of cadres that understand the principles of respectful maternal care. You could look at it from a research perspective and try to do implementation science research. You could do qualitative, quantitative studies to understand, descriptive studies just to understand how big the problem is. You can do interventional studies to try and compare which interventions work. You could also look at it from a policy perspective. Let's create policies that will insist on respectful maternity care. So at government level, ensuring that these are incorporated into policy and provincial policies, at clinical level, and putting it into guidelines, norms, standards of care. And then there's also looking at advocacy and lobby groups and creating public accountability. Next slide. Solutions for the solutions, if you look at it from an implementation perspective, will be mainly around restructuring clinic training, developing policies, system level quality improvement, increasing the human resources to ensure that there's enough staff. People are not having to look after 20, 30 laboring patients at the same time, but there's enough staff, enough people that are working, and the healthcare workers are not as stressed, and creating locally appropriate guidelines. And then qualitative studies, as I've mentioned. Next slide. The strategies overall would be to improve maternity care as a whole, not just looking at RMC, preventing unwanted pregnancies, increasing access to antenatal care, having skilled care during childbirth, safe surgery, postpartum care. And so these are your bigger, these are your approaches to improving maternity care as a whole. And within all of these, you would put in RMC at different levels to ensure that it fits into these approaches. Next slide. So the problem with the implementation approach is that whilst it's an excellent way of doing things and trying to cover all the bases, there's a danger of missing the mark because you're not targeting the actual problem. And so you need more than just an implementation approach. Next slide. So the range is a second component that you bring in, and just the understanding that respectful maternity care is a universal right for women, for childbearing women. And so bringing it, looking at it from a right and not only from a norm, and putting it as a norm. Next slide. And this ties up as well with the FIGO Human Rights Charter. And if you look at it from this perspective, you can tie up various principles and put them together. You can tie different. A woman has got a right to confidentiality and use that to enforce confidentiality as part of your RMC. And so understanding the human rights is, of course, an excellent way of trying to force RMC. Next slide. But then again, the problem with looking at it only from a human rights perspective is we know that not everyone is treated fairly, and justice is not there for not everyone receives justice. And so, famous words, farmer. If access to healthcare is considered a human right, who is considered human enough to have that right? So we all know it's a human right, but the violations continue. And it's because not everyone values everyone's human rights. Next slide. And then the other approach is looking at it from a human behavior perspective and trying to understand why people act the way they do. Trying to understand what the barriers are to RMC, trying to understand culture and context, because in many of the discussions, culture and context has come up quite a lot. And so I want to address that as well. And then just plainly understanding human behavior. Next slide. So what I want to raise is, we've spoken a lot about the fact that RMC happens in low and middle income countries, but I want to defy the myth that says that it's because it's culturally acceptable. It's not. Where I come from, we are taught principles of Ubuntu, principles of humanity. So it's not that RM's disrespectful care, abuse care is acceptable in certain settings. It isn't. Next slide. And the principles of Ubuntu, of course, are unity, sharing, caring, unity, trust. And so in many communities in Africa and India, many of us relate to this. This is what we are taught to understand. And so it's not when we say let's be culturally relevant and understand the context. We are not trying to say that RMC is only acceptable in certain cultures. It is part of our culture, but we need to start looking at who are the perpetrators of this type of behavior. Next slide. Then the last approach is looking at it from a social justice and equity perspective, saying that the childbirth experience is a cornerstone of health equity, understanding that we need to address the social systems that are rooted in histories of oppression, exploitation of women, racial inequality, etc. And when we start looking at this, it ties up back to the question of who is experiencing disrespectful care, who is not regarded as important as society, which women are not valued, and which women maternal death, of disrespectful care, of violence. Next slide. And so I get to the end of my talk, I want to clearly call it obstetric violence and say that this is an intersection between institutional violence and gender-based violence during pregnancy, that we should not be calling it disrespectful care because it is actually violence, it is cruelty, that when women are shouted at, abused, sexually abused inside hospitals, this is violence. We don't call it disrespect. It's the same as gender-based violence. We don't call it disrespect when somebody is physically abused. We call it violence. We call it a crime. So I want us to start thinking about disrespectful maternal care from a different perspective, because when you call it disrespectful care, it diminishes what it really is. It gives people an opportunity to say an option or not, and we need to start looking at it is unacceptable for women to experience this type of violence in hospitals. It is unacceptable for hospitals to create, not to protect the privacy of women that are laboring. And these things should be called what they are, and people should be made to account where possible for these kind of for this kind of discrimination. Next slide. And so in closing, what I've really tried to say to you today is we need to ensure effective communication and community engagement, understanding the communities we live in, the women that we treat. We need to provide care that is responsive to women's needs. We need to create respectful environments for healthcare workers. We need to create resources for sustainable behavior change. But it's not just we'll improve our behavior, but in a year's time, people go back to the way that they used to behave. We need to address inequity and discrimination, and we need to call it what and not call it disrespect. Thank you very much.
Thank you, Salome. That was an amazing presentation. Wonderful, really enjoyed that. I particularly like the holistic approach that you used when you were describing all the different ways to tackle the issue. And I love the fact that you said that we need to respect each other as well. Healthcare providers really do need to respect each other's to influence our practice. So I'm now going to hand you over to Kate, who's going to ask you some questions. We've got lots of really interesting questions. Kate.
So your first question is about the role of social media. What role does social media play in getting the message out to the community in Nigeria or South Africa that this hospital delivers respectful care?
So as some of you may know, I do advocacy. I've been doing this for a while now. And I think the first place I started with just simple advocacy for maternal health was through social media, was through Facebook, was through Twitter. And the more people listen to some of us saying the same over and over again, the more, the message goes out. But the thing with social media is who's listening. It's not just about telling our friends, but through social media, there are journalists, there are advocacy groups, there are leaders, there are politicians. And so there's a wide range of people that we could reach just through social media to change the narrative, to change the norm. When I started doing research on maternal health, on cesarean sections in South Africa, people didn't know that women in low and middle income countries were dying from cesarean sections, that cesarean sections were being underutilized, that women did not have access to cesarean sections. And at first, when I started saying women in Africa need increased access to cesarean sections, people started asking me, but isn't the world doing more cesarean sections than that? And it's social media that I have been able to get this word out, and now I speak on much wider, much big forums where I can speak to policymakers and influencers. So there is a clear role for all of us to be advocates for respectful maternity care in whatever capacity, and social media allows us to do that.
And Salome, do you have any practical tips for that? So early career researchers, how to actually write the right tweets, or what forums to use, etc.?
So we are very responsible in how we do it. And, being part of global health groups, being part of public health groups, I think, and, it's easier to give this kind of training and to, because one thing, for example, with the pandemic now, a lot of doctors went out to Twitter and, some spread, information that was not helpful, where they got so afraid that they would die, and misinformation and all of that. So I think it's not just a wake up and tweet, but we need to, in groups, we need to discuss what messages we actually want to take out and do it responsibly, so that's helpful. It's not there to break the system and to break, it's not a name and shame type of exercise, but it's being deliberate about what type of information to put through. And I think as academic groups, academic institutions, mentorship, we could work together, mentor each other, and so that students are not just are responsible in what they are putting out at the end of.
Okay, thank you for that answer, Salome. That's really helpful. So the next question is, do you see a link between respectful maternity care and the social, political and economic power of women? Do advocates for women's healthcare have a role in wider societal advocacy for gender equality?
Definitely. And that's why my talk has been really framed around women being in an unequal society. We're not important because it's when we start to understand how we value women, what the role of women are, that we're able to. So you could divide it up and say it's not separate issues. I don't see obstetric violence as a separate thing from gender-based violence, from the fact that women are unemployed or women are uneducated or women are poor. These are all symptoms of a society that not value their women, that are not empowering their women, not seeing the value in women. And so these things need to be led together. And as a woman myself, I understand some of these things. So sometimes I don't speak just as a healthcare worker. I speak as a woman who's experienced my own discrimination, who's experienced my own challenges. Even I've had cesarean sections myself, so I can talk about these things from my own personal experiences. So I don't think we need to separate advocacy for obstetric or for maternal care from advocacy that we do for women as a whole and empowering women in society.
Okay, that's great. Thank you. Another question that's come on the chat, which has kind of come across, so I'll merge the two questions, is what are the strategies or tools that can be used to quantify or measure the quantitative aspect of maternal disrespect, I think?
So I think, and why we need to quantify it it's simple questions that we need to ask. Is it happening or not in your setting? And it's descriptive studies really, where we're trying to see how many women are satisfied with the care that they get, how many women feel abused, how many women feel discriminated against. And these can be done as research topics. These can be qualitative studies where women are describing their experiences. But that is just the beginning. Quantifying it is one way of doing it. But I think more than quantifying it's we need to move to a place where we can honestly say that it is unacceptable and that there will be some sort of consequences for healthcare workers that are abusive, and I'm not trying to instill anything, but I'm just trying to say that we cannot sit back and put it as a nice to do type of thing. Respectful maternal care is not it's not an option. It's something that needs to be part of our everyday practice.
But if you don't measure it, Salome, how can we know that we've made improvements? I wonder if that's what the question was getting at.
So do we measure it? Do we wait while measuring it to say, it's like the example of a maternal death. Do we wait and say, let's wait for a certain period, count how many women have died, and then we're going to come up with measures to improve it? It's like a helicopter, it's like an aeroplane crash. Do we wait and count the number of aeroplane crashes, or is one crash one too many? We need to quantify, but we also need to put processes in place to stop it at the same time.
Action is now then, by the sounds of things. Okay, so the next question is about, we know that healthcare workers are overwhelmed. How do we incentivize them to provide emotional support or counselling during pregnancy and childbirth?
So that goes back to a health systems approach. It's a health systems issue. And, in part of the work that I've done, particularly on cesarean sections, one of our key findings were that women in poor health systems die from, are more likely to die from pregnancy related complications. And it's developing a health system approach, a facility approach. It's a leadership issue. How do we get leaders who understand their role as I'm here to create a conducive environment to ensure that we've got good outcomes so I see that more as a leadership issue, part of the leadership skills training that needs to be done, and not a one size fits all. We see it more in a country in South Africa where you've got private healthcare facilities and public healthcare facilities where and sometimes it's the same healthcare workers working in both, but in one they are well paid, they are happy, they've got they can talk to people that will address their concerns. They matter, they matter, their voice matters. But in a different hospital, you find that they don't matter, they're just a number. And it's not a quality improvement thing that you can prescribe and say this is what you do. It's a leadership issue, and getting healthcare managers and leaders and heads of department who see their role as also creating a conducive environment, not just for themselves and the healthcare workers that work there, but also for the patients that come into the facility. And I think, as Sean said, the business perspective, and I'm not saying that that's the only way to look at it, but I think what she was trying to highlight is what approach do we have to our healthcare facilities as managers and as leaders, and that's what will contribute to improving outcomes.
And can you share any advice on how to train those leaders? I think that's what we need to know.
There's I myself have done leadership courses, and it's things around understanding social intelligence, all of these things. It's a lot of things that being approachable as a leader. It's a lot of things that I would not be able to delve into in this session. It's another session on its own.
That's great. Thank you so much, Salome. So the next question is, how do the power dynamics or hierarchy, for example, between physicians and midwives, my app's just changed, drive mistreatment of women?
So I particularly am one person who likes to break the hierarchy, and working in my everyday job is in the surgical field. I work with departments of in a surgical department with other surgical disciplines, not just the obstetricians. And, so these things are highlighted more. We use hashtag patriarchy must fall, for example, because the whole system where the specialist is at the top of the food of the food chain, and the student is right at the bottom, and the midwife is right in between. That needs to change. We need to have a leadership structure, a model where everyone can listen to the other person, and it's not about a lot of medical outcomes are also influenced by the hierarchical model. Just the fact that somebody needs to get their anger on someone, and ultimately the patient tends to be the person who the victim at the end of the day. The nurses become the victims, and we can't go to work to victimize people at any level. And so the whole way that medicine is taught now needs to shift to a patient-centered approach, to a more engaging, a more welcoming approach, respecting and valuing each person, and not seeing yourself as I'm more important than you because I've got an MPCHB and you don't. That needs to change. That needs to fall away.
Can I ask a question?
Please.
Salome, there's been a lot of emphasis on respectful care of the woman, and I just wondered whether maybe you could talk for a minute about respectful care of the newborn as well, because the newborn has received relatively less attention until recently, so it'd be really good to hear your perspective on that.
All right. So I think, I'll talk about that. And I think also just respectful care of the family as well, and seeing not just the woman on her own, but many women come there with the husband, with the children. It's a family unit that's there. And then there's the newborn as well. And I think the approach we tend to have as midwives and obstetricians is deliver the baby and hand it over to somebody else. And that also needs to change, and for us to look at, it's seeing the newborn as a life, as valuing them from the time that they are born, and both from the pediatric side, so I think it's very important for us to not just see the woman as our only patient. And I mean, Tina, you've done a lot more work on this than me, but all I'm saying is completely support and agree and value what you're saying, and that it's important for us to bring this into our everyday practice.
And that obviously includes a stillborn baby as well, not just the live baby, I think, which people have struggled with in some places.
Mm-hmm. Mm-hmm. Definitely. My other research on stillbirths, and it's simple things like a woman who's grieving being put in a ward with women who've got live babies who are alive, and not doing the counseling, the caring, and as a whole, which is why I also brought in the mental health aspect, that women experience post-traumatic stress disorder after difficult pregnancy experiences. You know that not every pregnancy goes smoothly, but that there are difficult pregnancies where women experience complications. So the woman who ended up with a hysterectomy, who ended up losing the child, we need to create a space for them to grieve. We need to provide support. We need to provide counseling, and these things can be done. It's not things that, even without a full multidisciplinary team, there is something that all do to provide a supportive environment for women who have had adverse birth outcomes.
I think we've probably got time for maybe one more question.
Yes, I think so. So how can you improve respectful care in environments where women aren't respected?
So the question for me is, are you going to do it by policing it, and simply say it needs to happen, and we're going to put it in the guidelines, and this is what you need to do, and these are the norms? That's not sustainable. That's interventions that I have seen that have worked successfully were mainly to try and improve the environment as a whole, teaching healthcare workers that, I mean, in one study that I know that was done in Pretoria, they even found that the nurses didn't know each other's names. The midwives were working with each other, but there was such tension, such rivalry, and they went on, how can we improve this environment? How can we create spaces for people to start working together, to start knowing each other, to start valuing each other? And the more they did that, the more the healthcare workers started valuing their patients, and in this study that I'm describing, even the adverse outcomes were reduced. They had fewer stillbirths when they looked at this in its entirety. So I think there are interventions. I think my big thing is let's understand the drivers of it. Let's focus on not just the numbers and the quantifying, but how can we improve healthcare facilities for everyone that is part of the healthcare facility? And that requires leadership, commitment, and a vision that is that is sustainable, and practices that will be sustainable in the long run. So, there are some very practical things that I've proposed, and I don't also want to sound too ambitious and speak over the top and make it look like these things can be done. But I'm an optimist, and I do believe that when we work together to try and address things and try and improve the environment and focus on the soft skills, and that we've got a better chance to do better and to improve the environment for everyone that is in this caregiving sector.
Thank you so much.
Thank you so much, Salome. You had many, many questions and you answered them all so well, and we're delighted that you were able to contribute to this GLOW conference. Your contribution has been so valuable to us all, so thank you so much. We're now going to actually go to our break. If you could, go and look at the posters, or go and join one of the soapbox sessions, or listen to the music, do some yoga, or just relax. We've actually got a 30-minute break, which is great. So you've got plenty of time to go and put the kettle on, make a cup of tea, do whatever you want to do, or just unwind. And then we'll be coming back for the keynote speaker, which again is going to be a really, really interesting session. So do come back and join us soon. Thank you very much.
Those long summers, we played water fights, stayed up at night and dreamed of ways